Hi, it's Dr. Emily Cooper. Are you a healthcare professional who wants to expand your clinical expertise and your approach to treating obesity? Beginning November 7th, I'm offering a 3-part, 20-credit live virtual course through the Diabesity Institute. This course will focus on science-based insights into diagnosing and treating metabolic disorders. I've treated thousands of patients over the past 25 years. Our clinics recorded their outcomes in a comprehensive database, and I've learned a lot that I'd love to share with you. If you're looking for clarity, a greater diagnostic understanding, and effective treatment strategies, for more information and for the official credit statement, visit fatsciencepodcast.com and click on the provider course link at the top of the homepage. All right, now to the show.
All right, welcome to our bonus edition of Fat Science. This is just a little micro discussion. Play on words intended there. There's some stuff happening in the popular media right now, Dr. Cooper, that I think is really concerning because it goes against everything that we've talked about for over 100 episodes on this show. Mm-hmm. So we're going to be talking about microdosing, which is in full marketing just mode right now. Everywhere you look in popular media, they're just marketing, quote unquote, microdosed GLP-1s, and a lot of them are compounded. So we're going to talk about that. We're also going to talk about GLP-1 diets, which I'd love to start out with. I'm confused, Dr. Cooper, because I'm looking at all these ads, and in the fine print, which Big Pharma always has fine print because they have lots of lawyers and they need to, but they say these GLP-1s should be used with a low-calorie or reduced-calorie diet and exercise. Mm-hmm. What is going on? Why are they telling people to go on a diet when they're on GLP-1s?
And it's not so fine print if you see it on TV, because on TV, it's kind of a third of your screen.
Yeah. Well, this is a tough question. It really is, because I tend to, roll my eyes and say, well, that's just not the way that we work with our patients at all. But when you look at I can see why people say that, because the clinical trials with the GLP-1s all involved putting people on diets and the GLP-1. So before the medicine was released, all of the trials they did leading up to its FDA approval included the diets. Sometimes diet and exercise, but always some kind of calorie-reduced diet advice to the subjects that were participating in the clinical trials. So that, I can understand that, why, as they've been marketed, they carried that mantra with them. The other thing that's influencing it is that most of the research done with GLP-1s has been in people who are either on calorie-reduced diets or eating what's called ad lib, which means, what their appetite's saying. And most of the ad lib people were eating less than they were eating before they went on the GLP-1. So that's what the research that we have is showing. They did not do any kind of high quality long-term studies looking at people who were eating kind of the same amount of calories that they were eating before and taking the GLP-1, or just a normal amount of calories and eating the GLP-1. So it's
almost as if they have a bias going into these studies, that they're assuming that low calorie is going to lead to more weight loss and not thinking about the metabolic implications of calorie restriction. Is that what
true.
it is?
That's what's permeated the entire viewpoint and perspective around obesity, weight loss for decades and decades. And one of the things that kind of surprised me long ago, because I abandoned the whole calorie in, calorie out methodology long ago because I saw what it did to the patients. I thought, okay, well, that makes sense. Let's make these spreadsheets and let's put people on these reductions of X hundred calories per day and this much exercise at this, and measured all of these markers. And, it's true how Andrea always phrases it. You can force the body in the short term to do something, but in the long term, it did not work, even when they were staying on that plan. And, if they didn't continue to ramp up the exercise and reduce the calorie intake, they just were gaining weight. And not only that, sometimes it was like massively gaining weight. And there was a huge backlashes from doing this kind of thing. So right away, I'm thinking, do no harm. I'm a doctor. You're not supposed to do harm. So stop doing that. And so that, is what woke me up. And then since then, I haven't had anyone. This was like 25 years ago. So I haven't, not only have I not told anyone to do that, but I've monitored them to make sure they're not doing that. And so I just know from our clinical data that it's unnecessary to be doing these kind of things, these restricted calories when you take the GLP-1. Sure, it's going to change your appetite. But for some people, that means that they were already starving themselves before they started the GLP-1. Mm-hmm. So for some people that are told to eat normally, and they don't even know what normal is, so we have to use the dietitian to help us train them. But for some people, when they're eating normally, they're eating more than they were eating before they took the GLP-1. For others that had satiety impairment, maybe for a lot of those people, they were eating less. Once they were on the GLP-1 and just eating mechanically and normal eating. So it was just more like balancing their food to like a normal amount and what's called ordered eating, consistent schedule, and not at all eliminating food groups, doing fasting, doing calorie counting, reducing, aiming for less calories, not fueling your exercise. No, it's keeping the daily nutrition solid, adding exercise and supporting it with more fuel. And that's been the methodology I switched to 25 years ago because of what I saw with the other. And so I'm real happy with the results for the vast majority of our patients are doing really well. And I think our data stands up to anybody's data on that long-term data. So I'm convinced, and yes, it's true, there's not high quality research proving what I'm saying. So I'll admit that. But that doesn't mean that there is also not high quality research of long-term data showing what they're saying either. That this reduced calories is the best option for people 5 years down the road, 10 years down the road. That does not exist, that research data. So,
I think the hardest thing on GLP-1s is eating, like knowing to eat enough. It really, just from practical experience, because your brain isn't telling you, oh, I'm so hungry. Like, you have to really think.
yeah.
Because you're not starving. And you're not like, oh, breakfast time, oh, lunch time. Like, you do have to say, like, what you call mechanical eating and, like, just time snacks.
Right.
And my friends call me the snack queen because I'm like always, let's have snacks. And because you do have to really remember to do it. And you do have to like carry them with you. And I'm guilty of forgetting all the time because you got to keep getting it in.
But doesn't that make sense then? Why would you really try to tell people? So the message should
cut
really
it
be
out.
Fuel. Remember to reminding people fuel.
Right. And I
consistently.
think a lot of people, especially people who exercise a ton, which isn't me, okay, but they have to really, really be careful.
Sure.
Because I think that that's where you really, really get in trouble. Like, remember we had like a mailbag one about that, like the woman who exercised a lot and she didn't fuel a lot. Mm-hmm. Like, I think that you get in big trouble with that.
You can, yeah.
Well, it makes sense. And I think it also goes back to what we've talked about in previous episodes is that the fundamental misunderstanding of GLP-1 drugs is that you take a GLP-1 and it makes you eat less and you lose weight.
Right.
But what we've talked about so many times is that GLP-1 makes your brain feel secure and it stabilizes your entire metabolic system,
Right.
which leads to more fat loss. I mean, I'm
Mhm.
okay saying this. My wife started on a GLP-1. I think she's lost about 40 pounds. She hasn't changed how she's been eating at all.
Mm-mm.
And now she's having to buy new clothing and she feels great and she looks
Yeah.
great it's reversed diabetes. It's these drugs are amazing. So what I'm hearing, Dr. Cooper, is that I don't want to rant too much about this, but what I'm hearing you say is that the reason that the ads say reduce calorie diet with exercise is because that's how they were tested and approved in the approval process.
I think so. I think that's
Yeah.
why, and it's also, as you mentioned, a mentality bias that's just
Mhm.
ingrained in us.
Hmm.
The scolding, the condescending treatment of people,
Mhm.
and that have high weight. And a long time ago, this was many years ago now, I guess at least 10 years ago, a study came out. It was the longest term study by Sumithran, which I've referred to before. It's on our website under resources. We have a lot of the reference articles cited there. But his study, they looked at the hormones of metabolism just after a normal, like short term diet that people do, nothing extreme. And they looked at it for, I believe it was, the whole study period was like 18 months. So they did some pre diet hormone levels and then monitored afterwards for a year. So actually, it might have been, I don't know how many months it was, but it was more than a year. It was at the time the longest term, and I think still the longest term hormonal study after diets. And in that, it just showed pretty much all of the levers of the metabolic system were in a dysfunctional pattern after the diet and remained so that whole entire time. Didn't improve. Some of them even continued to worsen. And so those positions of the hormones would facilitate massive weight regain and abnormal weight regain because the metabolic system was left weaker than it was before the diet. And so I thought right away, oh, this will wake people up to this, that we shouldn't be approaching this type of problem, by putting people on these diets. But no, the conclusion was that they know the diets work to lower the weight in the first place, but what they need is a drug, basically, to keep the weight from coming back after the diet. I mean, that was the conclusion. And I just thought, this is just so not insightful. I can't believe it looking at that, they did not just say, wow, we got to find a different way, not cling to the diet after that. Because again, the whole point is do no harm. So if you're altering hormone states potentially long term by advising somebody to do this, that isn't that harm? And so in any case, but now that the GLP-1s are popularized, they're being marketed that way. This GLP-1 will enable you to, lose weight on this diet and not gain the weight back afterwards if you just stay on it. It's just a really faulty way of thinking, I think.
Well,
Yeah.
it's like that documentary that's out right now about the Biggest Loser people, and like some of the conclusions that were on there are really kind of faulty, and you can really smell them as you watch the thing because the people are sort of like, "Ooh, this wasn't a good idea," and a few of the people who said, "Oh, it was a good idea," you can tell that they were in it because they wanted to make a name for themselves, and you can tell what was good and what happened bad, and the people who had really horrible health issues with it, it shows, and you
Mm.
can see the horrible
Yeah.
side effects that happened from it.
Well, I haven't seen that, but I do know that there's a lot of pushback against some of the Biggest Loser
Oh,
reporting, of
yeah.
the fact that the metabolic system did slow down, and the people who lost the most weight, it slowed down the
Oh, they
most.
all gained it back.
Well, they didn't gain all
Not
of it
all.
back necessarily, but
Yeah.
the kind of reasoning that you hear behind that, which is trying to make our point less valid, is that, well, the metabolism slows down when you lose weight by any means. And to some degree that's true, because if we have a large body, it requires more fuel to maintain that body. Once we lose some weight, it doesn't require as much fuel to maintain the smaller body. So that's a predictable difference. But when we talk about metabolic adaptation, or what's called defensive body weight, or it's called biological adaptation. But when we talk about that, we're talking about a slowing of the metabolism in excess of that amount. That's the normal based on size. There's an exaggeration of the slowing due to the diet effect. So this is out of proportion with the change in the body weight. And so that's kind of what we're trying to avoid when we advise our patients not to do the calorie restriction, the fasting, the keto, the low carb. When they're on the GLP-1s, we're trying to avoid that out of proportion reduction of their metabolic rate as they're losing weight. We're trying to avoid exposing them to that, because what they showed with the Biggest Loser was that the people who lost the most weight had the most exaggerated slowing of their metabolic rate. They also were the ones that were doing the most exercise and calorie reduction
Yeah.
still. And so, and the researchers kind of think that's fine, that shows, oh, well, see, it's possible. All you have to do, if you've slowed your metabolism down that much, is just eat less and exercise more. That's all you have to do. Isn't that easy? To me, the patients that come to me, I mean, I don't know if these researchers actually have any patients. I don't think they do.
I don't think
I mean,
so.
I'm a clinician. I see thousands of patients, and they come crying when they're in this. They feel like they're in a food prison, an exercise prison, a food prison, that if they just let up a little, they're gonna blow up with their weight. So it isn't right. It isn't
No.
okay.
Well,
And
also the Biggest Loser people, they were exercising 5, 6 hours a day. Who does that?
yeah, I mean, well, and then they try to say that that's an outlier study because they did such exaggerated amounts. But it isn't true, because of Sumitran's study that showed just that regular diet and how it impacted these hormone levels. So I've gone, many decades trying to just raise awareness about this, and people can do what they want. Of course, we're not the police, but what I'm saying, if people are going to be our patients, and the people listening know this, because I don't have the patience for this either in our own patients if they don't get with the program here, because some of our patients, it's like, oh, I'm eating breakfast, a few times a week. And I'm like, what? A few times a week? Like, how long have you been doing this? That's not okay, because look at your labs and look at all of this. And so I'm not easy on people, because I feel like our job as the clinicians is to help this person get to a point where not only did they lose the weight, but their metabolism is still strong, and that they're capable of, they have better health, and their weight can stay balanced and not do all these crazy fluctuations, and that they are sturdy enough to introduce exercise and know how to fuel it and have a full life. So, but yeah, there's differences of opinion, and we'll keep getting attacked for our perspective, but I feel confident in it, just because maybe we don't have the research studies, but we have thousands of patients, that,
Who are much happier.
yeah, that it shows.
Yeah. I think what Andrea said is really profound too. That when you get on these GLP-1s, you guys, you're going to not feel hungry a lot of times, especially when you get up in the morning. But, I've gone to the mechanical eating and fuel throughout the day. I very often have a huge bowl of cereal right before bed because I'm kind
Me
of
too.
hungry, and I'm
With banana.
everything is optimal right now, Dr. Cooper, in terms of my relationship to food. I'm eating more now than I probably ever have, and my weight is not in excess like it was before. and all the
Right.
vitals are looking
Yeah.
good. And so I hope that those of you listening really take this to heart, that, Dr. Cooper has literally treated thousands and thousands of patients over the years. And the idea that your brain is secure is the fundamental tenet of what she's trying to
Yeah.
get across. And the idea of restricting calories as a means to losing weight really isn't supported by the science. So I think we covered that one. Andrea, why don't you set up the whole microdosing thing? Because, man, everywhere I
Everyone's
turn,
talking about microdosing. Everyone. They're like having their like little bits. They're like, oh, it just curbs my appetite a tiny bit, and I can hold. I can really just hold my weight, and it just like helps me just like not eat a lot, and I feel comfortable, and like I'm holding, and I don't feel hungry, and it's really good. And I'm like, well, I don't think that's how you're supposed to take it. I don't think that it's not about a diet. This is like you don't really have a problem, probably. I don't know. I mean, I guess if it's working for you, I'm not a doctor.
but what I think is interesting now is, Andrea, you spent your whole career in marketing. We are seeing entire ad campaigns
Everywhere I
that
turn,
explicitly say, let's microdose, and here's
everywhere.
a compounded GLP-1, and your life is going to
Yeah.
change. And
Oh, there's something called skinny, which I admit, if like 15 years ago, before I started with Dr. Cooper, I would of course like seen the word skinny and being like, I want to be it. I want to be skinny. I want to be skinny. And I see hims, hers. Who am I going to be? And I'm like, I literally in my Instagram, which, okay, I look at it too much, but every 5 seconds there's something like, don't you want to lose weight? Don't you? Like, it's like a snake coming out of my phone saying, just take a little, just take a little.
so,
And
Dr. Cooper, yeah, I think let's just speak straight to this. I mean, we did a whole episode on microdosing
Yeah.
recently, but now we're seeing
It's
specific
exploding.
campaigns
Yeah.
that are saying microdosing is the way to go.
Well,
And
and yeah,
that's
I
just
mean,
not scientific, is it?
well, no, but I think the marketing is the thing that they figured out. All it really is, you could replace this with any diet, any diet marketing, any diet supplement marketing. So they're trying to introduce the world, to this society, to this as if it's an innocent thing, like a little supplement, basically. And why not take this little supplement? It's a micro dose, so it's really small. So even if you don't know if you have a problem or not, maybe you don't have a real problem, or maybe it's just good to have it as an insurance thing, or some kind of short term thing you could try. I mean, it is, to me, it's frightening, as a doctor. And I know other doctors are like terrified of this. And the reason they're terrified is that it's the first time we've ever seen a medication that's sort of been, what do we want to say? It's been like hijacked and like being repackaged as almost like a supplement, like an innocent little supplement that almost like it's not a medical thing at all. So it's marketed, and not only that, a lot of the microdosing, like one that Andrea referred to, I saw, is being marketed as a pill, like a lozenge or a pill, and it's terzepatide as a pill, microdosed. I'm telling you, that has never ever been tested in any clinical trial. We don't have FDA approval for an oral form of terzepatide. It's never happened. It's never been studied. So whatever they're doing, it may not work at all, or it may be dangerous. We don't know. Nobody knows because it's not been tested. What is going on with this? Why is this being permitted? I mean, it could be creating like a major population-wide health risk. And but I feel like the people that are purchasing these things aren't the ones who are guilty at all, because they're just being subject to this insane marketing pressure and being manipulated psychologically. And the people that are responsible are the manufacturers and these companies that set themselves up as like a telehealth kind of thing, but it's really a drug manufacturing, supplement selling, drug selling operation. And so they won't profit if you don't buy their products. And if you go to a doctor, the doctors are not selling you products that they profit off of. They don't. Doctors, and as Mark has pointed out before, if doctors even take so much as a lunch from a drug company, it's reported in a database. So you can look it up. And as Mark said, ProPublica has like a listing there that you can look up your doctor and see if they're taking anything from, because that's like a myth that's out there that people are spreading, saying, well, the doctors are against all of this because they're in the pocket of pharma. Well, doctors are not in the pocket of pharma. They're not. It's a partnership because we need the pharmaceuticals to help our patients reach better health levels.
And
But we
find out what's coming out.
Right, and we're responsible for making sure that what we prescribe is safe and that it's in the context of that whole person's health, that it's indicated for that patient. But these telehealth compounded microdosing operations are completely outside of that.
Yeah,
And
but you see it. I got to tell you, you also see it. There's a couple of reality shows that I watch, and the supermodel-y type girls, they're taking it to not eat.
that's terrible. I mean, that
And they
is
did
not what
one
these.
show they did an intervention.
Oh gosh. Well, these are not, these medications are serious medications. They're for certain people. They're not for the whole entire population.
No.
And they're not for people who don't have a problem. And we talked about it in the microdosing before, that one of the concerns I have is like with such widespread use in population that doesn't
That
require
don't
it, we're
exactly. They don't have
creating,
a problem.
yeah, it may be creating problems where your own production of GLP-1 or GIP starts to be influenced by taking what's called exogenous, which means outside medication. By taking an artificial supply of that, your body recognizes that there. So then
could
it
mess
will
it up.
reduce your production to compensate for that, as it does with almost every hormone that we take. And so, how does that affect you long term and the strength long term? The other thing is that these are sophisticated proteins that our body could start producing antibodies that start
Oh,
to potentially attack our own hormones because of it. Because if our
and
body
create
starts
something horrible.
recognizing, yeah, because they're not bioidentical entirely. And so then it could be like your body's thinking, your immune system saying, what is this thing, this foreign thing? And could start reacting against it. And the concern has always been in the pharmaceutical industry. And this is something they test for in the clinical trials with their compounds to make sure that they don't have a triggering of our immune system where our immune system would start fighting our own natural hormones. But when you're looking at these off-label ones and untested compounds, that's not been done for those to see what's going on there. So the worst thing would be if it triggers an immune reaction, and then all of a sudden you're reacting to your own beneficial hormones, which could cause a tremendous problem. So I'm sure it's not common at all, but even if it's rare, it's really not a risk that people
Yeah,
should be taking.
not good. It's not a good
Well,
thing.
it seems like this is part of what's causing this is the confluence of a few factors, and one is the high cost of GLP-1s. The microdosing is a lot cheaper and more accessible. There are lower side effects by default because you're not taking the full dose of these drugs, but also the viral influence, like Andrea said, they're being peddled, and we all know that, just like the supplement companies, they're not obligated by law to prove what they say is true. The fine print always
Right.
says these statements have not been evaluated by the FDA and are not intended to treat any disease. And Dr. Cooper, I'm sort of a case study of, I
Yeah.
was untreated for almost 50 years of my life. And, I'm dealing with some calcium deposits in my coronary arteries now because for decades I had high blood pressure and high cholesterol and everything was bad. This is nothing to mess with. So if you're in your 20s and you have metabolic syndrome, for Pete's sake, get it treated by a professional, and don't think you can just casually treat it on your own. It's like, would you operate on yourself? I don't even do my own taxes. It's like, know your limits.
Leave it to the professionals.
Leave it to the professionals.
Not to some, Instagram person.
And it's hard because they make it one click away. I mean, they make it so accessible.
It is so
one
easy to
away.
click,
You don't
as
really
I
have
know.
to talk to a doctor. You fill out a form. You can lie on the form easily. You can then pick and choose, like you're picking off an ice cream shop menu, what you want without any advice, any counseling. And I know that's true because I had a few people run through some of these just to kind of test some of these telehealth sites and see what was required to get to the point where you're getting a prescription. It's really atrocious. And so
Well, no one sees, you don't have to have any proof.
right. It's more than a slippery slope. I used to say it's a slippery slope, but I think the train's left the station. It's now we're definitely in the middle of where these marketers are pushing meds that aren't FDA approved yet. They're still in the pipeline in forms that they've never been tested in undocumented dose strengths, undocumented sites of origin of where it came from, and no FDA testing behind it. And the marketing is just, of course, there's such big money in it because who are the people behind it? Well, they were in the
Venture
diet industry
capitalists.
before. The diet industry was marketing, I don't know how many, was it over 100 billion a year? I don't know what it is for the diet industry, but huge money. And then when the GLP-1, GIP train kind of left the station, the diet industry felt like, oh no, now we have to add the GLP-1, GIP to our model or else we're going to go under. So it's the same people, the same marketing strategies, the same blueprints of how you pick on people's vulnerabilities and how you emotionally pull those strings to get them to do that one click. And that ropes them in. And so it is real concerning. So
Yeah.
I
When the
think those-
algorithm people and the venture capitalists get together, you're in trouble.
So anyway, that's our take on it. I know a lot of people are frustrated by the whole system and feel like they have to turn to these for money saving. But I see a lot of things where I'm doubting that there is a lot of money saving in it because, maybe for some people there is, but I've seen so many issues with people coming to us after they've done those kind of online strategies and it hasn't worked for them and they've put a lot of money out. And so by the time they get on the actual real medication, they have spent more money than they would have if they had just, tried to get a good deal on the actual brand name medications.
Yeah, we are seeing some movement in that area, aren't we, Dr. Cooper, in terms of companies like Costco and others who are now offering GLP-1s at a reduced rate. Lilly Direct, you've mentioned that in the past. So
Yeah, and Costco's doing half price.
they're still expensive, but they're
Right.
not as expensive.
Yeah, and to clarify, Costco's not really doing anything special. That's been the price. That's been the cash
Oh, it
pay.
was?
That's been the cash pay price. So, for example, both Wegovy and Zepbound cash pay price is $4.99 a month. Now, it was that was guaranteed if you go through NovoCare Pharmacy for Wegovy or Lilly Direct for Zepbound. And then other pharmacies were able to do it too, but a lot of them were just kind of not wanting to deal with that process. And so I know in our area, a lot of small pharmacies have started to refuse to even carry the GLP-1s. So Costco, I think, was making a statement that they are carrying them. They are honoring this cash pay program.
Okay.
But they took advantage of it a little to make it seem like it was some kind of exclusive Costco thing, which was kind of a little bit not true.
I say good for them, though. Come on.
Yeah, but that's okay.
We love
That's okay. That's okay. We're glad that
Yeah.
you're offering it. The more, the merrier.
My pharmacy can't can't carry the drugs because they've been pushed out by CVS, actually.
Oh.
Oh, interesting.
Just so you know, CVS is trying to take over the world.
At least in the U.S.
Yeah.
Topic
I
for
guess.
another.
Oh,
We're
taking over the
talking a
US.
lot about U.S. policies, and we have listeners around the world, so
Right.
I'm sure it's totally different.
But it's
or-
it is kind of weird.
Yeah.
Well, I'm glad that we got to just discuss this, the whole microdosing
Yeah.
push, and also the quote unquote GLP-1 diets.
Yes.
So great information, Dr.
Keep
Cooper.
eating, everybody. Keep eating.
Eating. All
That's
right.
right.
Good food. Good food, though.
This has been another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.